And I am here on the podium, as you know, with Dr. Rosenman, who is the president of the Israel Heart Society. We have a terrific plenary joint session that has been put together by representatives of both of our organizations. And we're pleased to have our first speaker, who needs very little introduction to this community, Dr. Peter Ganz, who is the Chief of Cardiology at San Francisco General Hospital in San Francisco, California, where he's also Professor of Medicine at the University of California, San Francisco. Peter and I have known each other for 36 years. He was a senior resident when I was a struggling intern, and he hasn't changed a bit. Dr. Ganz.
Well, thank you for the introduction, Dr. Rosenman, Dr. O'Gara. If I haven't changed a bit, it implies I was born with white hair, and not much of it. So it's a real pleasure to be here in this Israeli-American symposium. And I was asked to speak about the history of endothelial function studies for over the last 25 years, where we've been and where we are heading. So I'm going to give a little bit of a historical perspective on endothelial function in humans, but I also want to focus on updating us and talk a little bit about the molecular basis of endothelial dysfunction, and also speak briefly about the role of endothelial function testing in personalized medicine. So let me start with the historical perspective. I think those of us who work in the endothelial field, myself or Amir Lerman, who's in the audience, and others, were really stimulated by the work of Robert Furchtgott, who published a seminal paper in 1980. Dr. Furchtgott was a pharmacologist, and he studied arteries in organ chambers. And he showed that in an intact artery with the endothelium intact, if you preconstrict the artery with, norepinephrine, and you then administer acetylcholine, my mouse isn't working, is there a pointer? Let me see if I can get a pointer. So if you administer acetylcholine in increasing concentrations, in the intact artery, you'll get endothelium-dependent dilation. In the endothelium-denuded artery, the vasodilation is lost and replaced by this paradoxical constriction. So Dr. Furchtgott really was the first one to draw attention to the importance of the endothelium, and specifically this endothelium-dependent vasodilation was dependent on the release of nitric oxide. So this was 1980. I was then a cardiology fellow, and I was listening to my father, who always told me I needed to work on something important, which he told, I think, everybody else in the world, and including several people in the audience told me that. So I, along with my colleagues at the Brigham, wanted to ask how the work that Dr. Furchtgott conducted in rabbits translated to humans. And I wanted to ask two questions. Does this endothelial vasodilator pathway exist in humans? And if it does, is it impaired in atherosclerosis? So there were no prior publications of endothelial function testing. We wanted to do this in coronary arteries because these were the most relevant arteries for cardiovascular events. And we designed the technology to do the measurements that resembled Dr. Furchtgott's experimental studies. We inserted a guiding catheter into the left main coronary artery, and through it we advanced a small infusion catheter to administer acetylcholine, which is an endothelium-dependent dilator, or nitroglycerin, an endothelium-independent dilator, and to see whether the epicardial artery is dilating or constricting, we use quantitative angiography. And what we found is shown in these two panels. In a healthy patient who had no coronary artery disease, and in this case we infused the circumflex artery, we show that compared to the baseline image on the left, you see the administration of acetylcholine elicited a vasodilator response. The artery got bigger in size. And subsequent studies showed that this was due to release of nitric oxide. This vasodilation could be blocked by the administration of nitric oxide synthesis inhibitors. So this was demonstration that this pathway, in fact, exists in humans. But in patients who have coronary disease, and this is a patient who had coronary disease in the right coronary artery, we are studying this diffusely diseased LAD, you can see that the administration of the same dose of acetylcholine compared to the baseline diameter caused vasoconstriction. So this diseased coronary artery had this abnormal vasoconstrictor response. And we published this observation in 1986. So it has been about, not 25 years, it's been 27 years. And we made the observation that atherosclerotic coronary arteries have a defect in endothelial vasodilator function. And we are very fortunate that this study was followed up by many other investigations of endothelial function by many other laboratories, including, as I said, Emil Lerman, who is really continuing this research at a very high level. So there's always a lesson to be derived from all of our publications. I already mentioned a lesson from my father, who always said, don't be afraid to work on something important. So I thought this was a pretty good start. Question was where to go with this next. So one of the directions that we took was to ask the question, does this vasodilation, this endothelium-dependent vasodilation, extend to other stimuli aside from acetylcholine? We are particularly interested in flow-mediated vasodilation. It's a physiologic stimulus, and at least in animals, other groups have already demonstrated this phenomenon, flow-mediated dilation. It wasn't clear whether this really occurred in humans or not. So we were interested in this and had to develop another methodology to study flow-mediated dilation in coronary arteries. And it was similar to what we had done with the acetylcholine responses, but this time we administered adenosine instead of acetylcholine. And we also advanced the infusion catheter further down the artery, so it was now about halfway down the LAD. And that gave us a proximal segment in the LAD, which was exposed to increased blood flow, but wasn't directly exposed to adenosine. So this was our experimental preparation of studying flow-mediated dilation in patients. We also had a coronary Doppler wire in the artery so we could monitor the increases in blood flow. And these were our results published in 3 different studies, but this is a good summary. And on the x-axis, you can see changes in blood flow measured with Doppler. On the y-axis is the amount of vasodilation. And as you can see, as you increase blood flow in a healthy artery, you get marked degrees of dilation. So for every fold increase in flow, you get about 6.4% dilation. But this response is almost completely gone in vessels that are even mildly atherosclerotic. So this demonstrated for the first time the presence of flow-mediated dilation in humans and its impairment in atherosclerosis. And I think its implication went beyond the coronary arteries because it laid the foundation for non-invasive testing of endothelial function, either by brachial ultrasound or by the EndoPad device. And again, there's a lesson, to me at least, with all of our studies. And this was putting this presentation together was a reminder to me that I was very fortunate to work with some very good fellows in the lab. Betsy Nabel was a fellow, and she then eventually became the director of the NHLBI. And Joe Vida, you probably also know, is the editor of JAHA, this new journal. So these are all very good people, and my lesson was I was very fortunate that our research went well because I surrounded myself with people who were far better than I was. And the last point I want to make before I get to the ongoing studies was that there was also a time when we knew that there was endothelial dysfunction, but we weren't sure it was reversible. Now today we take it for granted that endothelial dysfunction is reversible with treatments, but there was a time nobody really knew. So we looked at this systematically. We conducted a study in 49 patients who we randomized to either placebo treatment or cholesterol lowering in combination with Probicol, which was an antioxidant, and showed that in fact you can reverse endothelial dysfunction with statins and Probicol, and made the observation or speculated that this improvement in endothelial function then correlates with improvement in clinical outcomes. And I'm going to get back to this when I talk about personalized medicine. So this is all in the past. The lesson, I guess, from this study, for me personally, was that we recruited 49 patients and all of them completed the study, including the research catheterization, for which they came back a year later. They taught me about the importance of having a good relationship with your research subjects and explaining to them what you're doing, communicating your vision. So I want to actually transition from the past, and I could talk about the past for hours, but I think the future is more important. And I want to talk a little bit about where we are heading and explain what we are learning about the molecular basis of endothelial dysfunction. So much has been learned about the nitric oxide pathway in the endothelium, and this is a somewhat simplified version, but it shows the active product, nitric oxide on the right, made from the precursor amino acid allogenine. The enzyme is nitric oxide synthase, and this enzyme is activated in one of two ways, either by calcium, which occurs on a second-by-second basis, or by phosphorylation of a serine residue in position 1177. And that phosphorylation occurs through the PI3 kinase AKT pathway, as shown here. And this is more on an hour-by-hour change, not a second-by-second change. So this is how the normal pathway works, but the question is what goes awry in atherosclerosis and other cardiovascular diseases. And there are a number of mechanisms that can go awry that have been elucidated in experimental settings. An important mechanism is that nitric oxide can be made but quickly inactivated by excess superoxide. So at times of increased oxidative stress, superoxide will inactivate nitric oxide and form this vasoinactive substance, which is called peroxynitrite. Question is, where does superoxide come from? There are a number of potential sources. I'm going to say a little bit more in a second about mitochondria. When you have peroxynitrite formed, it's not a free radical, but it's a highly reactive species which will attack tyrosine residues in proteins to form nitrotyrosine. And nitrotyrosine can modify function of proteins, but it's also a useful footprint, useful evidence of increased oxidative stress. So if you see lots of nitrotyrosine, it implies that there was a lot of superoxide. Peroxynitrite also will attack tetrahydrobopterin, which is a cofactor, BH4. It's a cofactor that's required for nitric oxide synthesis. And in the absence of this cofactor, the enzyme becomes uncoupled. What that means is that instead of making nitric oxide, the enzyme will make superoxide. So a little bit of a positive feedback mechanism. And lastly, in some experimental models, the phosphorylation of enos, which is the more active form of the enzyme, the phosphorylated form, this phosphorylation doesn't occur, or occurs less. And there are other mechanisms that I won't go into now. So a lot has been learned about endothelial dysfunction in experimental settings. But what about in humans? So can we obtain evidence that these or other mechanisms that we've learned about in experimental models are operative in humans? So to answer this question, and this is really a rapidly evolving field, we need human endothelial cells, fresh endothelial cells, so we can investigate them at the molecular level. And an opportunity to obtain human endothelial cells came from a publication from Columbia, Feng and colleagues, who made the observation that if you put a guide wire into a human artery, even if you're relatively gentle, there's a very good chance that when you remove the guide wire, it will be coated with endothelial cells. And on the right-hand side, you just see an ultrasound image of a guide wire sitting in a human artery making contact with the vessel wall. So these endothelial cells can be dissociated from the guide wire. The purification of endothelial cells that's published involves several centrifugation steps. And at the end, you get a relatively few endothelial cells that are somewhat contaminated with leukocytes. Nonetheless, these studies have yielded some useful information. And there have been about 20 publications or so to date on endothelial, this is called endothelial biopsies. And one publication, which I just want to use to illustrate what endothelial biopsies can teach us, looked at the effects of aging on endothelial biology. Now, as you know, aging is the most important risk factor. And so this was a study that compared the endothelium of 23-year-olds to the endothelium of 63-year-olds. And this is now an immunostain where they quantified the amount of a pro-inflammatory protein, NF-kappa B, or an anti-inflammatory protein, I-kappa B. And you can see that the older subjects have an endothelium which is much more pro-inflammatory. There's more NF-kappa B and less of the inhibitor I-kappa B. And when you look at the expression of inflammatory cytokines, interleukin-6, TNF-alpha, MCP1, again, older endothelium has higher levels of these inflammatory cytokines. So to some degree it was important to do these studies, but the results were somewhat expected. But occasionally we also learn in these human studies that human endothelium is not the same as the endothelium in some of these experimental models. And one surprising finding has been that in older patients who have diminished nitric oxide, if you do the brachial reactivity test, there's clear evidence of less nitric oxide. The phosphoinos, the more active form of nitric oxide synthase, is actually upregulated. So unlike the downregulation, which is often seen in experimental models, what was seen here is upregulation. And this is seen with aging endothelium, but it's also been observed in human subjects who are obese or who are diabetic. So upregulation, which is thought to be compensatory, is something that wasn't expected. I think one major source of nitric oxide loss is its oxidative degradation by superoxide. And this is a study from Joe Vita's group in Boston. And Joe basically looked at the endothelium removed by this biopsy technique in diabetics compared to healthy subjects, measured the nitrotyrosine level within the endothelium, which is now the footprint of oxidative destruction of nitric oxide, and showed much higher levels of nitrotyrosine in diabetic subjects. So the question is, where does the superoxide come from? And Joe very much was interested in the potential role of mitochondria. Now, for those of you who don't know much about mitochondria, in healthy cells, whether they are endothelial cells or any other cell in the body, mitochondria function in networks. They are not isolated individual mitochondria, but they fuse to form these very efficient networks. And usually these networks are associated with fairly low levels of oxidative stress. Now, Joe asked the question in these human endothelial biopsies, what's happening to mitochondria in diabetics compared to healthy subjects? And what he basically showed there on the left panel, that says control, the left upper in the green color, you can see networks of mitochondria. So this is what's been described in experimental settings. But what Joe showed for the first time, this has only never been shown in even animals, is that diabetics endothelium really doesn't have these networks. The networks that have dissociated, so you see individual mitochondria, and these are associated with very high production of superoxide. And interestingly, this transition from networks to individual mitochondria is closely regulated by several enzymes. One of them is called fission protein 1, FIS1. And again, in diabetics, you can see there in that lower panel, the diabetics have upregulated level of FIS1. So again, we are learning a lot about dysfunction of endothelium, whether it's at protein levels or level of these organelles, like mitochondria. So this current method has been a major advance, but it has limitations. We get relatively few endothelial cells, less than 100 from any one patient. And because you need at least 20 endothelial cells to measure one protein, because there's so much variability from cell to cell in the amount of protein, you need a good statistical sample, that if you have less than 100 cells, typically you can't really look at more than 3 or 4 proteins in any one patient. And also these cells are heavily contaminated with blood leukocytes, and this really precludes examination of either messenger RNA or microRNA. So you can look at proteins, but when you do RNA work, you basically end up homogenizing on all the cells, and if the cells are contaminated, you'll be including the contaminated RNA with your endothelial RNA. So the existing method really doesn't permit RNA examination. So my lab has developed a new approach to purifying these cells. Instead of centrifugation steps, we just use flow cytometry. And I won't go through the details, but we basically have changed the method. So instead of less than 100 cells, we get 4,000 or 5,000 cells typically. And these cells are essentially 100% pure now. So they permit work at the level of RNA. And that's shown on this slide here, that when we look at our endothelial fraction, or what we think is our leukocyte fraction, based on the surface markers, and we then look at the expression of various types of RNA, as you would expect in the endothelial cells, we see high expression of messenger RNA for von Willebrand factor and eNOS. In what we think is the leukocyte fraction, we can confirm it because there is high expression of mRNA for CD45. But what's really exciting is that we can actually now measure microRNA in human endothelial cells. And you can see that the endothelial cell, as you would expect, has a very high expression of microRNA 126, which is, as expected, lacking in leukocytes, but basically shows that we now have pure populations of cells, which will enable us to do RNA studies. So this is really, I would say, a dawn of a new era, that we can complement human endothelial physiology with a new understanding of the underlying molecular biology. So I kind of suggest you stay tuned, but there'll be, I think, many developments over the next few years. And I just want to finish, I think I just have 3 or 4 more slides, with the idea of applying endothelial function studies to personalized medicine. And just to remind you, one aspect of personalized medicine is to find which patients benefit from what treatments. And when we look at our best therapies like statins, and we celebrate statins, these are some of the placebo-controlled statin trials showing reductions in event rates ranging from 25 to 38%. The names of the trials are listed below. So we celebrate our successes, but we ignore our failures. If you reduce events by 25%, that means you haven't eliminated 75% of events. So replotted here is the remaining events compared to the placebo, just reminding us that most of our patients fail our statin treatment, and it's our best medication. And personalized medicine, in the context of treatments, would differentiate the non-responders from responders before it's too late. Now, I mentioned to you that we did endothelial function studies all the way back in the 1990s, but we never emphasized the fact that if you study 100 patients and you give all of them a statin, you will get a wide range of responses among individual patients. Some patients' endothelial function will improve with statins, others may not, or it may get a lesser improvement. And this previously was viewed as inconvenient noise, and we didn't emphasize this in our studies. But the question was always, is this really noise, or is there a message there? Is the variability in improvement of endothelial function a predictor who would derive a clinical benefit from being on a drug or not? So this was now more recently examined by several investigators. This is one study to illustrate the point from Japan, from Kita and colleagues. And they studied 251 patients with newly diagnosed coronary disease who weren't on any treatment at the time of diagnosis. And they tested their endothelial function at baseline before initiation of treatment and after 6 months of treatment. And then they followed patients for an additional 2.9 years. And the idea here is, if you look at on the left-hand side, persistently impaired endothelial function, FMD, this was about 40% of patients who were put on maximal medical treatment, achieved their targets in terms of blood pressure, cholesterol. These were American targets, even though it was a Japanese study. And about 60% of their patients normalized their endothelial function, meaning the FMD was greater than 5.5%. So 40% of the patients remained with in 40% of patients, endothelial function remained abnormal despite treatment, and in the other 60%, it improved. But what happened to outcomes? When patients in whom patients in whom endothelial function improved, had far better outcomes than those patients in whom the endothelial function was persistently impaired. In those patients who continued to have abnormal endothelial function, the event rate was almost 3 times as high as it was in patients whose endothelial function did improve. So the endothelial function is no longer viewed as an inconvenient noise. It is actually something that's of prognostic significance. So this is really a proof of principle. This is not ready necessarily yet for clinical application. I think what we need is office-based physiologic measures of endothelial function, such as what Itamar is developing here in Israel. But I also think that endothelial biopsies may be very useful to tell us at the molecular level why some patients benefit and other patients do not. So this is my last slide, just a reminder that we've been at endothelial function or endothelial biology now for many years, stimulated by work of Robert Furchtgott, basic science, that we found a way to translate this to humans by doing physiologic testing of endothelial function. But now we've entered a new era when we are beginning to study endothelial dysfunction at the molecular level, and also hoping to apply endothelial function studies to personalizing medicine. So thank you very much for inviting me. It's a pleasure to be here. Thank you.